You'll tell me if you can't hear me or something?
Yeah.
Okay. Good morning, everyone. Can you hear me? Good morning. Welcome to Breakfast at Blake. My name is Melissa Allen, and I am honored to represent both Blake and the Office of Institutional Advancement, who are the hosts of this event. I'm your host today because I'm a proud member of the class of 1982, which means I'm a Blake alum, and I'm also vice president of our Blake Alumni Board. And in case you didn't know, our Blake Alumni Board is a group of about 30 of us volunteers from all different Blake classes who collaborate with the Advancement Office and the school to support events like this, which provide meaningful ways for us alums to connect with each other. Well, one of the many things we share as alums is an appreciation of excellence and outstanding performance. And our speaker today, Lucy Cosgrove, class of 2001, embodies those traits. She's not only our speaker, but the recipient of the 2021 Outstanding Young Alumna Award. Yes. And we are especially lucky to have Lucy with us today because she was originally scheduled to speak in February, but her family was in quarantine due to COVID-19. So thankfully everyone is healthy, and we appreciate Lucy and the school and all of your patience as we reschedule to this beautiful day. So before we hear from Lucy, please join me in welcoming our head of school, Dr. Ann Stabney, to present Lucy with her award.
Thank you, Melissa, and good morning. It's great to see all of you here this morning. I have the distinct pleasure of introducing, presenting our 2021 Young Alumni of the Year Award to Lucy Cosgrove, class of 2021. Well represented right here. Lucy is class of 2001. Yes, you're younger than, yes, very young. Lucy is an epidemiologist for the Minnesota Department of Health, where she leads programs to vaccinate children who are uninsured or enrolled in Medicaid. Lucy has taken on many roles with the MDH since the pandemic began a little over 2 years ago. She has investigated COVID-19 cases, served as MDH liaison to local public health directors, created protocols for summer camps, performed contact tracing for schools and childcare providers. For the past 15 months, Lucy has led the team that operationalizes the distribution of COVID-19 vaccines throughout the state. I have to say, yay for that. Before joining the MDH, Lucy worked as a family home visitor for Way to Grow, a nonprofit focused on kindergarten readiness. She also served as an English teacher for World Teach in Costa Rica and as a volunteer medical interpreter and patient advocate at the Phillips Neighborhood Clinic. Lucy joined Blake in 8th grade. While at Blake, she participated in tennis and was captain of the alpine ski team. She was also a member of SIAC, that's our Student Interaction Council, and a homecoming queen. After graduating in 2001, Lucy went on to receive an undergraduate degree from University of Puget Sound and a Master of Public Health from the University of Minnesota. She lives in Minneapolis with her husband, Joe Larson, and their 2 young children. Before we honor Lucy with her award, I would like to share with you all a special surprise video.
Congratulations on being honored as the Blake Young Alumna of the Year Award for this year. You deserve it so much. It's been way too long since I saw you, but you were always one of the smartest and kindest people that I had the pleasure of being friends with at Blake. So congratulations. See ya.
Yay. Okay. The Young Alumna of the Year Award honors a member of our alumni community who has demonstrated outstanding leadership, achievement, and influence in their field and community. Lucy, we honor you today with this citation. The Blake School recognizes Lucy Cosgrove for her outstanding contributions to the field of public health, for her leadership and service throughout the global COVID-19 pandemic, and for a profound commitment to and significant impact on the health of fellow Minnesotans. It's my pleasure to present to you Blake's 2021 Young Alumna of the Year Award. Congratulations, Lucy.
Thank you so much. Thank you so much. Well, that was a big surprise. Good morning, everyone, and thank you so much for being here today. I know some of you might be kind of tired of hearing about COVID-19. Maybe that's just me, but I appreciate you giving space to talk about it this morning with me and hear about my experiences. Yes, as was mentioned earlier, my family got caught up in the Omicron blizzard in February, so again, thank you for your flexibility and willingness to reschedule. We are very happy to be healthy on the other side of that. And before I begin, I want to give some special thank yous. So first, thank you to the Blake Alumni Board. I am very humbled to receive this award and was touched by the timeliness of your decision to highlight a public health experience. I know you had a lot of other options, and it really is an honor for me to accept this award, so thank you. Second, I want to acknowledge that there are likely hundreds of healthcare professionals in the Blake community that have put their health and the health of their families on the line for the past 2 years. I'm deeply appreciative to all of you and the roles that you have assumed throughout this response. And just a warning, I'm a sap, so I might cry a little bit. It's okay, I'll be fine. So here comes the family and friend part. I can do this. So finally, I want to thank my family and friends, some of whom are here today. My aunts sent notes of encouragement, and friends dropped off cookies and let me vent. My husband, Joe, who is a middle school teacher, took on the additional stress of distance teaching while also managing the evening witching hours and bedtime duties with 2 little kids. Thank you. While I worked 12 to 15-hour days, 7 days a week for several months. He even made homemade dinners and brought them up to my desk to make sure I was eating. For those who don't know, Joe's late father, Greg Larson, was a choir teacher who taught at this very school for several years. My mother-in-law, Lori Larson, cared for both of our kids during the spring of 2020, and for our youngest, Adeline, every weekday for over a year. And she continues to care for her 2 days a week. I would have quit my job if it weren't for her support and generosity. And our family friend and retired teacher, Nancy, helped our son, Greg, with online kindergarten for over 7 months. And finally, my parents and sisters. You answered the phone and provided a listening ear and words of encouragement when I really needed it. My mom had the lucky role of temporary online kindergarten teacher for Greg for the first 2 months of the school year, after I placed a desperate call for help. For some reason, I thought it would be possible to just manage the COVID vaccine response with my 5-year-old next to me learning how to read. I know it wasn't easy for anyone, and this group was there for my children during an unpredictable time in their lives while I committed more time to a job that really needed me. I'm grateful to them all, and I know what a privilege it is to have such a strong village. So my goal this morning is to share my experiences about working in the infectious disease division at the Minnesota Department of Health throughout the pandemic, and in particular, my experiences working on the team that operationalized the distribution of COVID-19 vaccines. I learned lessons about flexibility, keeping very minimal expectations, and that achieving equitable vaccination coverage is complicated. I hope that we'll all have a shared understanding that investing in public health will set ourselves up for success for the next pandemic. And yes, there will be another one. But unfortunately, I am not Mike Osterholm, and I didn't bring my crystal ball, so I'm not here to predict the future of the pandemic today. So before I dive in, I just want to briefly mention my Blake background. I joined Blake in 8th grade, and I was immediately of the tight-knit Blake opened my world to teachers that encouraged critical thinking and that sparked curiosity in their classrooms. As was mentioned earlier, I was on the tennis team, and I spent many years on the alpine ski team under the coaching of Bob Teslow. One of my favorite Blake memories isn't one that I'm most proud of, but it does bring a smile to my face, and that was learning a lesson about using my free time wisely. In 9th grade, I had a free period. I'm not sure if those are still a thing, but unbeknownst to me, some of my friends had placed something a little grotesque in my locker. And upon opening it, I screamed and started laughing and accusing those around me of putting it there. And about 20 seconds later, to our surprise, Mr. Woolman came out of his classroom and invited us to sit on the floor in the middle of the room of the circle of desks of his 10th grade English classroom for the remainder of the period. As a freshman, this was absolutely mortifying, but I did learn to be a little bit quieter and wiser with my free time after that. So after Blake, I went to the University of Puget Sound in Tacoma, Washington, where I studied political science and Spanish, and then taught English in Costa Rica for a year. And when I came back, I began my first full-time job as a family home visitor for a nonprofit in Minneapolis called Way to Grow. While I was working at Way to Grow, I learned about the health issues facing the families and communities that I was working with, and I was interested in the idea of preventative upstream policies. After 3 years of home visiting, I pursued a degree in public health at the University of Minnesota. So, public health. I feel like prior to the pandemic, a lot of people didn't know what public health is. I think everyone now has a better understanding of the role that public health plays, but before the pandemic, it played a foundational role in the background of our lives. Some of the infamous accomplishments of the last century include tobacco control, fluoridation of drinking water, food safety, and then, of course, the development of vaccines. Public health focuses on the social determinants of health, the idea that the structural conditions in which we're born, grow, work, live, and age matter, and that they can predict our health outcomes. While I was in grad school, I started a job at the Minnesota Department of Health as a student worker. It was a pretty glamorous gig, first focused on a lot of data entry. I gathered boxes of paper immunization records from the basements of clinics and entered them into our state immunization database called MIC. Some of you might have an app on your phones called Docket. Anyone? You should have it if you don't. Docket pulls your immunization records right from MIC, and it's an easy way to display your proof of COVID-19 vaccination, so you should download it if you don't have it. But over the past 10 years, my role has been coordinating the Minnesota Vaccines for Children program, or as we call it, VFC. It's a federal entitlement program that was created in 1994 after a 2-year measles outbreak that produced tens of thousands of cases of measles and hundreds of deaths between 1989 and 1991. After the outbreak, it was discovered that over half of the kids who contracted measles were not vaccinated, even though they had seen a healthcare provider during that time. The VFC program reduces those missed opportunities and creates affordable access to all childhood recommended vaccines for children right in their medical homes. The bread and butter of the program is the distribution of childhood and seasonal influenza vaccines. So as you can probably gather, the distribution of COVID-19 vaccines logically fell right into my team's lap. So over the past decade at MDH, at the Minnesota Department of Health, we've worked through the measles outbreaks of 2011 and 2017 and the fungal meningitis response in 2012. We've provided vaccines for mass vaccination exercises where we partner with pharmacies and local public health agencies and school-based clinics. We'd run through scenarios of various vaccine work and define barriers and ways to collaborate across sectors to prepare for the next pandemic. I always left those meetings feeling invigorated and hopeful, but also with a very heavy sense of responsibility. The technological tools at our disposal felt antiquated, and I imagined the logistical challenges we would face if we had to stand them up at a fast-paced pandemic-sized level. In fact, I vividly remember sitting around a bonfire with friends one night a few years ago, saying how I'd prefer to be in a different role before a pandemic happened. And then, before I knew it, it was March 2020. So, in March of 2020, I huddled in a large conference room with 50 to 100 of my colleagues while our state deputy epidemiologist briefed us on the latest case numbers. And he said, "This may be the pandemic of our lifetime. Many of us will have family, neighbors, and friends that will die." It sent shivers down my spine, still does. and very unfortunately turned out to be true. At that moment, we also all looked at each other around the room and thought, okay, so maybe now is a good time to not be crammed in a conference room together, and perhaps we should walk the talk and maybe start to social distance. And soon after that, we started to work from home. So throughout the response, this is a great meme for, I think, most people's experiences throughout the last 2 years. I assumed a lot of roles. Initially, when we were drinking water from the water hose, the fire hose, nearly every MDH employee was assigned to the COVID response. And those of us who were already in the infectious disease division were the first to get to work. In February, our emerging infections supervisor briefed us on the COVID tsunami to come. And I remember so clearly her saying, okay, it's time for everybody to become an expert on everything related to COVID. Let's go. And soon we were all performing case investigations, and I worked on the public hotline. I later became the liaison to local public health directors and joined the school's childcare and summer programming team, where I assisted childcare centers with contact tracing and authored summer programming COVID-19 guidance. By the end of June of 2020, it was already clear that vaccines were coming, although we had no idea how effective they would be yet. And a colleague and I were reassigned to building out technology to make vaccine distribution more efficient. Imagining the distribution of a vaccine in very high demand for the entire state was daunting. And we were using platforms created in the early 2000s that had patchwork updates since then. It was very hard to sleep anticipating it all. So the planning phase began. I think the phrase building the plane while flying it has become a bit ubiquitous over the past 2 years, but I honestly can't think of a better analogy for the COVID-19 vaccine response work. By September, most of our team was assigned back to our area, and 3 things became clear. Our biggest challenges awaited, and they came in the form of time, or lack thereof, logistics, and the scale of the work that needed to be done. Rumor had it that vaccine distribution could start by the end of the calendar year. We knew to pull all of this off, our existing partnerships with CDC and our local public health colleagues would be more important than ever. The fall of 2020 was a flurry of nonstop meetings in collaboration with our federal and local partners. And soon, we met our new military partners from the Department of Defense and the Trump administration's Operation Warp Speed. Operation Warp Speed played an orchestrating role in vaccine allocations, and I found myself on phone calls with Army generals saying things like, over, in the meetings. Then began webinars with vaccine manufacturers, Pfizer and Moderna. Pfizer had trainings where we looked in total amazement and dread at the logistics of storing vaccines in ultra-low cold temperatures. Moderna's vaccine could be stored at typical freezer temperatures. So kudos to Blake's outstanding alumni of the year, Dr. Stephen Hogue, who is the president of Moderna, for creating a vaccine that did not need to be stored in ultra-low cold temperatures. He not only saved a lot of lives, but also a lot of sweat on the behalf of healthcare professionals handling vaccines. So while we continued to build the plane as we were ready for the takeoff of the vaccine campaign, the data management portion of our responsibilities became incredible. Our team was responsible for recruiting and enrolling over 1,700 providers as COVID-19 vaccinators in Minnesota. Some were experienced, well-oiled vaccinating machines, while others were brand new to the world of vaccinations. Provider registration information needed to be uploaded into CDC's brand new data lake. In the same time frame, we learned the file specifications needed to transmit vaccine orders from our state ordering database to CDC's. New processes were created in approximately 10 days before placing our first COVID-19 vaccine orders. November 2020 was also when we became aware of a brand new robust database called Tiberius from Operation Warp Speed. It allowed us to track and monitor vaccine shipments. So in a matter of a short couple of weeks, we learned the new federal data systems, stood up in-house procedures to ensure a smooth vaccination process in Minnesota. We hoped. None of the connections between these databases were automated. While we felt the pressure of operationalizing vaccine distribution, our colleagues on the epi side of the response were drowning in record high case numbers. Everyone across the agency was working on overdrive. So one of the biggest lessons we learned from the H1N1 pandemic was that the process of distributing vaccines wasn't perceived as being fair. In a strong effort to not repeat history, we formed a COVID-19 Vaccine Allocation Advisory Committee. The group included experts from across the state who reviewed guidelines from the CDC about who should get vaccine first, and then made us recommendations to us about how to apply those guidelines here in Minnesota. The idea was that the advisory group would provide recommendations to ensure equitable distribution of vaccines. Ultimately, the final decisions about vaccine distribution came from the governor's office. And due to political decisions later in the response, our advisory group stopped meeting after December. This was the first hint of how intertwined politics would become in decision making. I'm probably not doing it justice, but let's just say that the planning phase was challenging. And there's a saying that says that anticipation can be the worst part. But I'm not really sure that was true in this case, because implementing our vaccine distribution plans pushed me to personal limits that I have never experienced before. So, December 2020, the vaccine campaign began. I'm sure we can all recall this moment when the FDA approved Pfizer's COVID-19 vaccine for emergency use authorization. I felt a mix of emotions that day: hope, joy, also anxiety that a headline would hit the Star Tribune about Minnesota's vaccine distribution system failing. Thankfully, that did not happen, and there was plenty of criticism and political surprises along the way. So, how did we do this? Following the guidance of our allocation group, healthcare professionals on the front lines and long-term care residents were the first to vaccinate. To account for geographic parity, each week 80% of our supply was distributed on a pro rata basis to providers within these healthcare regions in Minnesota. An additional 10% were distributed to regions with higher social vulnerability index scores, meaning they had higher proportions of populations living in poverty that made them more vulnerable to contracting COVID-19. The remaining 10% went to tribal health clinics each week. During this time, urgent and constantly changing data requests from the governor's office were nonstop, 7 days a week. My team's primary role, other than responding to a flurry of data requests at all hours of the day, was to get vaccines where they needed to go at the time that they needed to be there. It sounded simple enough. Turned out to be a little bit more complicated than that. There were first and second doses to manage. There were vaccine redistributions to track. There were multiple vaccine manufacturers with different timelines and wildly different minimum order quantities, not to mention the unique storage and handling requirements to comply with. So the nature of the vaccine shipment schedules meant we needed to place vaccine orders on specific timelines, often over the weekend, and due to scarce supply, there was absolutely no room for error. We double-checked every order quantity and shipping address prior to placing all orders. So I remember in the very first week of distribution, the governor's office was looking for a photo opportunity to celebrate the arrival of vaccines in Minnesota. And we needed to just let him know where to go, right? Well, somehow we sent the governor to the wrong location. Thankfully, there was time to get him to the right place, but that was the first of many incidents that caused a bit of anxiety and offered an opportunity to choose to either laugh or cry. And thankfully, at that point, we were still laughing. So I really can't underestimate how logistically challenging this whole vaccine rollout was, from the Operation Warp Speed to vaccine manufacturers to UPS and FedEx employees, not to mention people like you getting your arms to the location where the vaccine was first available, oftentimes on a moment's notice. It was challenging and somehow very successful. So Pfizer vaccines were shipped to large healthcare hubs with ultra-low cold freezers where they could then be broken down into smaller quantities and sent to clinics throughout the state. They then had to report that information back to us to ensure that doses were going to registered providers. This is a map of over 2,000 unique routes of vaccine redistribution around the state. To date, our team has helped facilitate the redistribution of over 250,000 doses, some of which might have otherwise gone to waste. So a large portion of our Moderna vaccines were prioritized for smaller providers and providers practicing or participating in the Pharmacy Partnership Program, also known as the PPP, and they vaccinated long-term care residents and staff. So one night in early January, my son Greg, who was 5 at the time, came upstairs to say goodnight, and he heard me in a meeting discussing the PPP program. And he looked at me and he said, "Mom, the PPP, is there a poop, poop, poop program too?" Greg's preschool humor was the highlight of many days. And occasionally he'd pop upstairs to tell a joke or to show me a piece of artwork he'd made. And this is a photo of a drawing he made of me working upstairs in our house. So within 9 days of the vaccine distribution happening, there was a headline that hit the front page of the Star Tribune. Safety net clinics yet to see vaccine. Smaller clinics who didn't have ultra-low cold freezers had yet to see vaccine because Moderna was just hitting the market. A larger healthcare system in this article also voiced opposition to our allocation plans, stating that we were not providing their fair share of doses. It later turned out that hundreds of healthcare workers within that organization who were working exclusively from home were vaccinated in the early weeks of the campaign. And that was a group that was not prioritized by our guidelines. This was one of many powerful moments for me, seeing how the media obtains and shares information. The health system knew the right power play to get the media's attention. Maybe things would go their way. I am definitely a more discerning consumer of media since living through the inside lens of the vaccine response. And I think that consuming information from the media still remains a large challenge for many of us. I'm not able to advance the slide. Can someone help me out? Thank you. So, towards the end of January, Governor Walz and the Biden administration pivoted from our allocation plans. And guess what? Our team found out via the New York Times, probably with all of you at the same timeline. There were several times when my colleagues and I became aware of shifts in policy and guidelines straight from the media and not from CDC. We joked about getting us all free subscriptions so we could properly stay informed. But anyway, we were instructed to share the limited vaccine supply with a large new priority group that was originally slated for a couple more weeks down the road, and that was adults 65 and older. At the same time, new provider metrics needed to be followed and to speed up vaccination. Every provider had to use 90% of their vaccine inventory within 72 hours of delivery. The goal was to be the speediest vaccine administration nationally, and the New York Times began tracking state metrics on their website. The focus became about speed and less about equity. This put enormous stress on vaccinators, and it made it essential to have near-perfect distribution timelines. Mass vaccination clinics were set up for adults 65 and older, and our partners focusing on long-term care residents and harder-to-reach populations very much struggled to meet the demands of the 72-hour rule. Due to the abrupt change in expectations, partnerships were strained. In the end, though, we got to the goal of being #1 on the New York Times vaccine tracker, and we were the speediest at vaccine administration that week. So where are we now? Ultimately, I am very proud of the work that we did to get Minnesotans vaccinated as soon as possible. Our immediate divisional leadership led with the science. Some of you may know that our division director, Chris Erzman, retired in early February. Working for her and Commissioner Malcolm and other managers in our area is an honor, and their leadership is the reason that Minnesota did so well. Can you advance the slide, please? So here's where Minnesota is right now for vaccination rates. The definition continues to shift as vaccine recommendations evolve with the pandemic. But currently, you're up to date with your COVID-19 vaccinations if you've received all recommended doses in the primary series and 1 booster once you're eligible. Getting a second booster is not necessarily considered to be up to date yet. This may look a little dismal, so in a more positive light, 70% of Minnesotans ages 5 and older have completed their primary vaccine series. There were challenges throughout the response with our communications to the public. I'm sure you could all agree with that. Relationships with our local partners, and it was hard being in the messenger role. The intertwining of politics and decision-making and the abrupt pivot from our equity-focused plans was a very hard pill to swallow, especially while being at the helm of operationalizing the process and having control over where places ultimately went. Therefore, I was compelled to do what I thought was, and that was tiring. We still have a lot of work to do to get Minnesotans vaccinated and to increase global vaccination rates. In Minnesota, across all age groups, there are 15 to 20% differences in COVID-19 vaccination coverage in people enrolled in Minnesota healthcare programs like Medicaid compared to people with private insurance, meaning that across the lifespan, people enrolled in Medicaid have significantly lower COVID-19 vaccination rates compared to those with private health insurance. Achieving high vaccination rates and equitable vaccination coverage is complicated. Access is only part of the solution. We know that gaps in coverage among certain childhood vaccines are due to a myriad of reasons. Access is certainly one hurdle, cost is another. Thankfully, that wasn't as much of an issue with COVID-19. And the most pivotal is trust. trusting messengers are the key to increasing vaccination rates and overcoming misinformation. As the vaccine campaign evolved and politics became a little less embedded in decision-making, a large team was formed to support the work of community vaccination clinics that are promoted, hosted, and run by culturally competent and linguistically appropriate members from their communities. Global distribution of vaccines is not equitable. I think we all know that. Wealthier nations received doses far before poorer nations. Turns out not every government can invest $18 billion in vaccine development and distribution. Trust remains a part of the gap in motivating people to get vaccinated, and that's a hurdle that's going to take time to overcome. And until we achieve higher global vaccination coverage, COVID-19 will remain a threat to us all. But I would say, with the good, the bad, and the ugly experiences of the past 2 years, I am grateful I had the opportunity to be part of such a large effort during a unique time in our history. In 2020, when Joe was teaching from home, I remember my dad joking that I'd have a sexier story for our grandchildren to tell them about our lives during the pandemic, but that Joe's story as an educator was no less meaningful or important. How true. In September, when Joe was teaching middle schoolers from home, I overheard him making jokes and trying to get kids energized and engaged online. It brought me so much pride to hear him teach, and I felt the heaviness of the responsibility on his shoulders in that moment too. We've all been through the ringer and contributed more than we signed up for in these past 2 years. One thing that this pandemic has taught me is that being kind can go a long way. On any given day, I corresponded through many emails with other public health professionals that were facing their own emotional limits. And giving people grace, especially during stressful periods, always went a long way. And ultimately, I would have lost steam for listening for friends and family. After a very stressful, and now I can look back and think a comical week in March of 2021, my parents offered one of the best gifts we can give. The gift of laughter and a healthy dose of perspective. This is a picture of my birthday card that year, and to be clear, I am the toothbrush. Finally, I want to end with some thoughts from Paul Farmer. He was a medical anthropologist and physician and preached the importance of elevating healthcare for the poor for decades. He passed away last month. One of my favorite quotes from him is from a commencement address he gave to a group of public health graduates. He said, "Make public health matter. The most important way to do this is to think about those poorly served by modern medicine and public health today. They are legion, even in this country. You're going to have to fix it. The good news is you have many tools at your disposal, and we can develop many more if we put our minds to it." Public health matters. I hope that we learn from this pandemic, continue to invest in public health, and not take it for granted. And I hope this can be an apolitical agreement. None of us want our daily lives interrupted by public health policies. Our lives should be made healthier by them. I know that everyone at MDH is looking forward to getting back to routine work and quietly stepping out of the spotlight. Thank you so much for being here today and for listening. I appreciate the opportunity.
Lucy, thank you so much for an educational, inspiring, and moving presentation, and for all you've done for the state. You truly are our outstanding young alum. You have proven it many times over. We do have time for some questions. Those of you who are here in person, if you want to raise your hand if you have a question, I believe Kristen has a microphone and she will come to you. We've also had some questions. We told people who were calling in or watching virtually, they could send in questions. So I'll start with one question just to kick things off, Lucy. Was there any experience or mentor at Blake that kind of laid the foundation or planted the seeds for you to epidemiology?
I think I was kind of a late bloomer when it came to my interest in public health. I really became aware of what public health was after working at Way to Grow. But I think what Blake has done for me just across my educational path and certainly in my careers is just inspired me to be curious and to try new things and to not be afraid to fail, honestly. I think it was very stressful being at Blake in some ways, where you're surrounded by so many talented classmates who, but it was so inspiring for me to join the Blake community when I did right before high school, and to just learn that it's okay to try new things and to be curious and to explore all the options that there are. So that's what I would say about that.
Yeah, that's a great point. Anybody have any questions?
Hi, I'm Josie. Thank you for being here. Just the epicenter of the pandemic and helping the state of Minnesota. And what you said about Blake being stressful, I'm guessing there are a lot of talented people around you and you're able to handle it easily because of that. So, way to pass out the wisdom. My question is around not having the COVID to pass, and so when we get vaccinated, we're still passing it, so people are taking tests to say that they don't have COVID, but that doesn't mean they're not a carrier, as I understand, so if you could give us some information about that.
Sure. I'm not the best expert in that area, but I know that there is a lot coming out recently, particularly talking about the antigen test, and especially as we move to this new model of the response, where a lot of folks aren't coming back positive. People who come back positive on a PCR, if they take a COVID antigen test the same day, only like 26% of them are coming back positive on that antigen, like at-home test. So it takes longer, we're finding, to test positive on like a rapid home test, or antigen test. And so there is some danger there in trying to say, like, oh, I'm going to test myself this morning, then I can go off and mingle with 400 people and I'll be fine. There are gaps there. And so I think it's important for us all to remember that, and I don't know if this is happening to you in your circles, but certainly everyone I know with small children went through I don't know anyone really who got through the blizzard of Omicron without getting COVID if they had small children in schools or childcare. But now we're kind of in this new phase where those of us who have had it might have a little bit more confidence, and there is new data showing that past infection does have long-lasting immunity. But I don't know that I'm fully answering your question. I guess I'm saying is it's complicated, and I think that as this pandemic evolves, that's one of our biggest challenges in public health, is to make clear information available to the public on what the safe options are. So I guess I would say know that taking an antigen test before going to mingle with hundreds of people is not 100% sure bet that you're not going to either transmit it to others or obviously contract it from someone else while you're there. But continuing to use common sense measures to get through this, I think, is what we all have to do, and to think about those in your circle that you're worried of exposing, and to take a more conservative route if you have immunocompromised family members or people that you live with that you want to protect. But I know there's a lot of data that will probably be coming out in the next several months telling us more about what tools are at our disposal that we can continue to use to keep ourselves safe. And that's one of the biggest challenges of this whole thing.
Lucy, Andy Rich from Class of 99.
Hi, Andy.
Curious about your experience with COVID-19 vaccines. What learnings or experience transfers to the childhood vaccine work as you go back to, hopefully someday more day-to-day?
Yes, thank you. That's a great question. It's been humbling. It was last Friday that our team put out the special newsletter to all of our enrolled providers saying, hey, we're seeing significant gaps in coverage, COVID-19 coverage, on kids who are enrolled in Medicaid versus privately insured children. And that's, again, through all ages that we're seeing that gap. The measles outbreak in 2011 inspired us to start a work group internally where, I'll just be transparent, the Minnesota Department of Health immunization program is 95% white women. And we realized after that pandemic that there were at the time very large gaps in MMR coverage for Somali children in Minnesota in particular. And so we realized we needed to recruit staff from those communities and to have, you know, peer-to-peer education. And so we learned a lot of lessons that way, and we did see increase in vaccination rates there. I think the lessons that we're learning from COVID-19 is, again, we are in charge of access, and then implementing equitable distribution also lies at the hands of providers, right, who are receiving the vaccine. So helping them understand where the gaps are and helping them prioritize the, you know, getting kids with lower coverage rates into the offices, I think is where the biggest barriers are. You know, it's easy for those of us with cars to hop in and go to appointments and get vaccinated when they need to be there. So, you know, and then the other thing about COVID-19 is cost wasn't a barrier. And so that's another thing that translates to our childhood vaccines for kids who are eligible for our Minnesota Vaccines for Children program, is those are also free of cost. The vaccine itself is free of cost to kids to get, if they can get to the clinic. There's a big discussion on rural pharmacies. Pharmacies play a huge role in the vaccine response, in the COVID response. They